My name is Dr. Aisha Gul, working as a women medical officer with Government of Sindh, Pakistan. I'm enrolled in postgraduate diploma endocrinology in University of South Wales, UK. For module 6, I have been given assignment of fine needle aspiration thyroid. To begin with, let's discuss about what is thyroid. Thyroid is an endocrine gland in front of neck located below Adam's apple, as shown in picture. It consists of two lobes, lower 2 by 3rd are connected by isthmus. It plays a major role in maintaining and regulating metabolism, heart rate, growth, and development of human body. Therefore, any abnormality in the thyroid disrupts metabolism and hence affects the whole body. These abnormalities can be in the form of hyperthyroidism, hypothyroidism, thyroid nodules, and malignancy. When a thyroid nodule is palpable clinically, the next step in the intervention to detect the nature of thyroid nodules or to see if the thyroid nodule is malignant or not, fine needle aspiration of thyroid is performed. There are a few aspects important to understand as far as fine needle aspiration is concerned, such as the precautions before the procedure, how is it performed, indications of procedure, contraindications of it, risk involved in the procedure, and how to interpret fine needle aspiration thyroid. Let's discuss these pointers one by one. The definition. It is a procedure when the small sample of thyroid tissue is removed to check what is the issue with thyroid gland, such as shown in the image. Let's discuss the precautions that need to be taken before the procedure. Stop taking any blood thinners before the procedure. However, you may drink or eat normally before the procedure. The procedure. Patient lies on the back with the head tipped backward so the neck is extendable. Then area is made aseptic and then a local anesthetic, preferably 1% lidocaine, is given before the needle insertion. The use of ultrasound machine or probe not only provides direct view of thyroid but also prevents from local damage to the surrounding structures during the procedure. After cleaning the area, a thin fine needle is inserted into the thyroid gland. Then the needle is advanced into the nodule. The needle is attached with a syringe which can apply suction and remove cells from the nodule. After removal of the needle, cells are placed on the slide and then sent for pathological assessment. Indications of the procedure. Fine needle aspiration thyroid is performed when a solitary thyroid nodule of more than 1 cm or even less than 1 cm with presence of risk factors is present. However, it can also be performed when the multiple nodules of more than 1 cm are present. Contraindications of the procedure. Bleeding diathesis, uncooperative patient, and in those patients who cannot suppress the cough. Risks involved in the procedure are thyroid bleeding, infection, damage to the structures near the thyroid such as damage to the recurrent laryngeal nerve and the superior laryngeal nerve. Interpretation of fine needle aspiration cytology. The interpretation is based on the presence or absence of follicles, cellular size, staining characteristics of cells, presence of nuclear grooves, colloid, and lymphocytes. According to Bethesda system, fine needle aspiration cytology can be interpreted as grade 1 or category 1 when the sample is non-diagnostic. In such condition, repetition of FINAC with ultrasound is recommended. Category 2 is when the sample comes benign or adequate sample but with atypical features is present on the slide. In such cases, the case should be clinically correlated. Grade 3 or category 3 is when neoplasm with atypical features comes on the slide. In such cases, repetition of fine needle aspiration and discussion with multidisciplinary team is recommended. Category 4 is when the follicular neoplasm is suspected. In such cases, again, Either a lobectomy is performed after discussion with multidisciplinary team. Category 5 is when the malignancy is suspected. In such cases, total thyroidectomy or lobectomy is performed with or without frozen section, hemithyroidectomy. Category 6 is when there is confirmation of malignancy. In such cases, total thyroidectomy is performed. As far as category 2, which is thyroid adenoma, is concerned, certain characteristics of thyroid adenoma are well-defined borders, its a hyper-echogenic peripheral vascularity and absence of microcalcifications, as compared to its carcinogenic or malignant part, which has irregular margins, is tall, hypoechogenic, has increased central blood flow and microcalcifications. Thyroid adenoma can be in the form of papillary and follicular types, with the follicular type most common. Histologically, the adenoma is separated from surroundings by a capsule which makes it clinically palpable mass, as shown in the image. The thyroid carcinoma can be in the form of poorly differentiated and well differentiated types, with the papillary type most common. Bethesda category 4 follicular neoplasm or suspicious for a follicular neoplasm is used for cases with a cellular aspirate comprised of follicular cells showing cell crowding or microfollicle formation. Cases cytologically suspected for follicular adenoma and carcinoma are included. Final diagnosis is based on tissue histology because capsular or vascular invasions are the essential criteria for its diagnosis. Cytologically, the papillary carcinoma can be diagnosed by the presence of psammoma bodies and orphan any-eyed nuclei. Medullary thyroid cancer can be diagnosed by spindle-shaped cells with eccentric nuclei and intranuclear inclusions as shown in the image. The calcitonin stain also comes positive for medullary thyroid carcinoma. Anaplastic thyroid carcinoma shows extreme cellular pleomorphism, hence it is poorly differentiated category. It has multinucleated giant cells also present. I am very thankful for your interest.